The most important prognostic factors in myeloma relate to both the age of the patient and the genetic underpinnings of the disease. We tend to measure a patient's frailty in terms of how fit they are to undergo therapy, such as autologous stem cell transplant. We don't use a specific age cutoff, although around the age of 74, 75 tends to be the transition point beyond which we feel uncomfortable applying high-dose chemotherapy and transplant. Beyond age, we look at other comorbidities, presence of peripheral neuropathy, cardiac disease, diabetes, all influence our choice of initial therapy. The most significant biomarkers that we can use for progression include blood tests such as the beta-2 microglobulin, which when elevated indicates a poor prognosis. Beyond that, we tend to rely on genetic testing. Genetic testing is usually performed by FISH analysis or fluorescence in situ hybridization. It can identify 8 different forms of myeloma, some of which are high risk and some of which are low risk. We usually apply those parameters mostly to the younger, fit, healthy patients in deciding how aggressive to be with treatment. In the older, more frail patient, we tend to favor a more continuous therapy approach, which is less dependent on those prognostic features and more dependent on comorbidities. In those patients, use of convenient, oral, and well-tolerated regimens is favored, such as the use of lenalidomide and dexamethasone, and perhaps with the addition of bortezomib in patients who can tolerate a weekly injection.